We're going to be checking in Jasper. We're going to go through the process of going through the admission form and the whole list of things that we do when we check a patient in for a procedure. So Jasper is going to have a large growth removal. We're going to send that in for biopsy. So first thing we'll do is get our admission form that we'll go through. We'll pull him up on the screen. We have Jasper here. We can see he's a 4-year-old neutered Great Pyrenees. He weighs 106.8 pounds. We can see the owner information up here, Ronald Burmeister, phone number, all that information. So what first thing we need to do is just write down any of the information about if he is not up to date on rabies or Bordetella. We need to know all that information because he's going to be staying in the hospital with us at least for today. We need to check on blood work because we always do pre-anesthetic blood work. We need to make sure that he's up to date on a heartworm test because we'll check that prior to anesthesia. So now we're going to look through the records to see, we are paperless. For the most part, obviously we have to use some paper, but most of our records are going to be in AVIMARK. So we definitely want to check vaccine history. So you can see down here all these tabs. So we have the vaccine tab. We'll just click on that and make sure he's up to date on his vaccines. We do require rabies, distemper, and Bordetella to be up to date. And he's up to date on 2 out of the 3. He is due for the kennel cough vaccine. So we'll talk to the owner and Dr. Less about if we want to do that. Usually we will, as long as they don't have any major medical problems going on right now. We're just removing a mass. So as we go through, we'll just mark what needs to be done, and this will be scanned in to his account, attached to records, so where the doctor or anyone can pull this up and look at information, you know, where we can reach the owner and if they've ever given any aspirin and what blood work needs to be done, and make sure that we get a signature at the bottom. So obviously we're not going to go through all of that, but we also need to make sure that blood work has already been ran very recently, and that was just ran yesterday. So we can pull it up to make sure everything's looking okay. And we can see here our abnormals show up in red, so glucose is just slightly elevated. So that looks good for the chemistries. And then our CBC.
Trixie, I just noticed there was no GA1 or 2 in there. So I put them in,
it also looks very good, but we'll make sure Dr. Les takes a look at that before we anesthetize him. So that's our
I think maybe double check just to make sure,
admission
but
form.
I couldn't see him anywhere in there.
Okay. And then also our release consent form. This is the same setup. We just use this as a consent to admit the patient for a specific procedure, and we'll go through that with the owner. Once they're checked in, we have a cage card with last name, first name of the patient. We do write on here if they're having any abnormalities, you know, diarrhea, vomiting, if we need to get urine, if we need to get a fecal, if they have seizures. And then we write the procedure that they're going to be having at the bottom and what kennel they're going to be staying in and their weight. So that goes on the kennel, and then for the patient themselves, we have a collar that we write up for them, a paper collar, that way they don't end up getting snagged on. You know, they don't keep their regular collar on when they're in our kennels. So we write what kennel they're going to be staying in, their weight, last name, first name, and then I again repeat what kennel they're going to be staying in. That way anybody can look at this patient, whether they're in their kennel or not, and know who it is. So we make sure to secure that on them, on every single patient. So for this patient, we are going to be removing a mass and sending it into Iowa State University for histopath. So we would write down all of our pertinent information for, about the owner and the patient, and also about the sample itself. So we would go through and fill out shape, color, size, any additional tissues. We mark where we removed it from, and it's near the preputial area that we're going to be removing this mass. And then clinical signs, duration, location, treatment response, gross features, tentative diagnosis. A lot of times the doctor will want us to write down there what we think, and also special concerns. And we usually grant them permission to provide duplicate results to the veterinary teaching hospital too. So that is that. And then once we anesthetize, then we would have our anesthesia form. And that's a lot of information going into here. So we would print a label which has all the patient information on here and the owner information too, which, you know, breed, sex, age, last name, first name, weight. And then we just go through and fill out what doctor's doing the surgery, who the anesthesia tech is, surgical tech, our pre-anesthetic drugs, if there's any abnormalities prior to the pre-med, and make sure we have this. We added this section for the doctor to check the blood work, just to make sure that we are pulling that up before we anesthetize them. So weight, temp, heart rate, respiratory rate, mucous membranes, capillary refill time, body condition score, and then pain scale. That's all included on here as well. So, and then we just go through and mark what we used, what size endotracheal tube, what gauge catheter, when we started anesthesia, ended it, and what we're monitoring while they're under anesthesia. Whoops, I didn't mean to do that. If they have a non-rebreather or rebreather, we rarely use the ventilator, but we do have to use it sometimes. What size bag? And then we'll just go through and put our symbols next to where we're seeing, and we not only use monitors, but we manually check as much as we can, you know, heart rate, respiratory rate, gum color. And then we've started putting emergency drugs down here too, just in case. That way we don't have to run and get a doctor if a patient wakes up really rough. So we usually use metoprolol as our post-anesthetic emergency drug. And then if we use local anesthesia, we have that information in here. And then after we extubate, we put what time we extubated, and then what the heart rate, respiratory rate, and the temperature was. So that pretty much encompasses everything for our anesthesia form. And then when we send a patient home, we would just consider this like a minor surgery. So it would be up to the doctor if we're okay to feed that night or not. And then we would just make sure to mark, you know, suture removal is due in 10 to 14 days. We set this up with Dr. Wes. He's going to be doing this surgery. And then we have pretty much stopped using fentanyl patches. We started using Recovera instead, so we have a different form that we'll need to fill out for that. But any other oral medications that we would need to send home with them, we'll write down milligrams, name of the drug, and how much to give and how often, when we gave it last and when it's due again, and any other comments we have down here. And this includes his name, the owner's name, today's date. And this is the patient ID number. It's really helpful to have that for identification purposes. Oh, actually, that is the client number up there. This is our Recovera consent form. This is a newer one to us, but we've started using this, so we have to get consent from the owner to use this and make sure they are aware of what they need to do. We're not supposed to have children around the patient for 3 days. And then adults just need to be really careful about where they're petting and washing their hands. So we just make sure they print, put the name of the dog, and sign, and then we'll date it. And then we'll keep that in their records. And we'll scan it in, and then we'll send it home with them so they have that information to read through. Okay. We are going to get Sophie out and restrain her for a blood draw. So we're going to demonstrate how we would do that. So we'll get her out. Sometimes they have a tendency to bolt out. So we'll just gently put a leash around her. There, sweetie. She's a little sleepy. And then we're going to bring her over here, there's a couple of different ways that you can restrain for, come here, sweetie, for a blood draw. Come here, sweetie. Come here. If you're going to do a jugular draw on a bigger dog, which I would consider her a bigger dog, it's okay, honey. Sometimes you don't even need to make them sit, depending on their personality. You can just hold their head up, make sure they're secured in between your legs. Any sort of leash or collar, you want to get that out of the way. And that way, the person drawing the blood can hold off the thoracic inlet and feel for the vein, just get everything out of the way. And your job is to make sure that they're not thrashing and they're not able to bite. They're holding still. If we wanted to do a blood draw from the cephalic vein, we could still stand like this. Sometimes it's nicer to make them sit so it's a little bit more comfortable for you. And then you just take your thumb and hold off, but make sure you're supporting that elbow, keeping that leg out, and also still making sure they're not able to bite. So I think that's the two that we'll stick with on that blood draw. Put her back in there. Sometimes they really fight and don't want to go back into their kennel. Come here, sweetie. Sophie's a really nice girl, but she's really getting kind of nervous. So for her, I'm just going to scoop her up and gently put her back into her kennel. It definitely doesn't help anything to try to drag them over there or wrestle them. Sometimes it's unavoidable, but definitely the less stress you put on the patient, the easier it's going to be for everyone. So we're going to muzzle Dewey, show how that's properly done. Sometimes it's really easy to muzzle patients, but then the other times you have to be really, really cautious because they're already trying to snap at you and get at the muzzle. But in this case, he's just really nervous, so we're doing it for some extra precaution. So the best way to do it is to just make sure they can't necessarily see you coming and try to get it on as fast as possible because they're going to try to whip their face around and paw at it. Make sure it's loose enough that you're not having to unloosen it when you're working on getting it on. It's easier to tighten it when it's on than it is to try to make it looser. So there we go. Make sure you have a nice fit around the muzzle so that it's not too tight on them, but they can't get their mouth open to bite you. Kinsey, we're going to be doing a TPLO today on her left hind, obviously. So I'm just going to do a quick pre-anesthetic exam and then give her her pre-med. So the first thing I'll do is just check the temperature, make sure that's normal, and then we'll listen to her heart and her lungs. Check her gum color, capillary refill time. Okay, we're at 101.9, which is good. Hi, sweetie. She's a little nervous. It's okay. It's okay. I'm not gonna hurt you. Good. Less than 2. Nice and pink. I know, sweet. It's okay. So we're at about 160 right now. So counted 40 beats in 15 seconds and we'll multiply that times 4. Her lungs sound great. So some people like to give intramuscular injections in the leg, but I actually prefer to do lumbar muscle. So we'll feel through the spine and then we'll go about 2 fingers over. No, sweetie, draw back, make sure you're not getting any blood. Okay, good girl. Our ASA grade for our patient today, Kinsey, was 1 because we didn't have any abnormalities. She's free of disease and she's young and she's healthy. We're going to draw blood on Willie from his saphenous vein. We wet it down with alcohol and Dana is going to restrain him. He's a bit wiggly. I like to use a 1 cc syringe. So the suction is not too much so as to collapse the vein. Hey, buddy. Okay, Willie. Sometimes it helps to shave a little spot, and if you're not getting good blood flow, you can squeeze the foot a little bit. We don't need very much. So Dana's going to put some pressure on that, and then with these, it's good to have a bandage ready right away because they'll start squirming and wiggling, and it's kind of an awkward spot, so you want to get it wrapped up right away. Okay. I'm going to draw blood on Rose today. We're doing a jugular hope. So we're holding off, and we already put some alcohol. And then uncap our needle. Make sure your bevel is up.
Good girl.
And we're using a Vacutainer.
Good girl, Rose.
Nice, good flow. Make sure it's full. So we're going to spin this down and send it in for an ACTH stim. So, and then we'll remove the tube and then remove the needle and hold some pressure on that spot where we poked her.
Good.
So we're doing a jugular draw on Breezy. She's a little crabby, so we're going slow. Holding off at the thoracic inlet. Feeling for our vein, we already used our alcohol. Make sure your bevel is up. Definitely tough skin. Okay. Alright, we'll just put some pressure on that spot. Make sure first. Okay. This is Crazy Sammy, and we're going to try to draw some blood for a heartworm test. So, Bree is holding off the vein holding off the leg so the vein sticks out, and we rubbed it with alcohol. He's crazy. Gotta move fast with him. Okay, they all have 15 seconds, but put some pressure on that as long as we can. Okay. So we're going to discuss the minimum required database. Technically, you only need to check a packed cell volume, total protein or total solids, blood glucose, and blood urea nitrogen if you're doing surgery on a young healthy patient, but our particular hospital requires us to do a full complete blood count, and we check chemistries on all of our patients as well. On the younger patients, we just do like a pre-anesthetic profile using a VET scan. If there's any abnormalities on that prior to anesthesia, then we will continue further. Or if it's a sick or injured patient, then say for instance we have a patient that's going under anesthesia for a mass removal, and we know because we've done cytologies that the cells are proven to be cancerous, a sarcoma for instance, and we would like to know if it has metastasized to the lungs. So then we will take chest rads or radiographs, 3 views, to make sure that the lungs are clear, because that may determine if we are going to pursue surgery or if we're going to just discuss doing chemo instead. If it's a patient that's been hit by a car, it's really helpful to do chest rads as well, to see if there's like a pneumothorax. Those are definitely things you want to know before going into surgery. Putting them under anesthesia, they're an increased risk. Sometimes we'll see abnormalities, elevated liver enzymes, that may prompt us to do a, can't think of it right now. Total loss of what I was going to say. Where you feed and then you bile acids test. Wow. So if you want to find out if there is more underlying disease than what we were initially thinking, because sometimes we're just blindsided by something when the animal seems fine, and we check blood work and we find some abnormalities, or we'll find out they're diabetic or they have kidney disease. All things that we need to pay close attention to. Sometimes we'll even have young cats or dogs that come in for spay or neuter, and they end up having a high white blood cell count or low platelets. So those are all things that we would need to pursue prior to going under anesthesia. We don't ignore those things. That's exactly why we do pre-anesthetic blood work. And definitely prior to putting them under anesthesia, we're checking the temperature, we're listening to their heart and lungs, listening for a heart murmur, because just because they're young doesn't mean they're not going to have any abnormalities. We've seen plenty of patients that are sick even at a young age. Age doesn't determine if you're healthy or not. ECG, I'm not sure if I mentioned that on the hit by car. Sometimes they're in shock, and we would need to pay attention to if there's any VPCs being thrown, life-threatening, if you're putting them under anesthesia and you're not aware of what's going on, and sometimes even with that knowledge they don't make it. We just had a patient recently that died because of that, post-anesthesia. So we try to be as careful as possible when it comes to that. And then when we find abnormalities, we adjust our pre-med accordingly. Or if we already know, say the patient has a heart condition, oftentimes we're going to need to drastically adjust our medications that we're giving in our pre-anesthetic sedation. For instance, we don't give acepromazine to a patient that has a history of seizures. We also don't give it to boxers because there's been some research that has shown the possibility that it can cause problems with them. We induce with etomidate instead of propofol if we have a patient that has a heart condition. Every doctor is different in how they determine what they want to give for pre-anesthetic sedation. Some like their patients to be more sedate than others. One of our doctors only primarily gives glycopyrrolate and morphine, but then we have another that will do medetomidine in addition to those two, or acepromazine. The reason the particular doctor, Dr. Wedeking, she explained to me that she doesn't like to give acepromazine is that it lowers the blood pressure. So she'd rather have a patient that's a little bit more alert prior to going under anesthesia than having to deal with blood pressure issues, because it is stressful when their blood pressure is dropping. We've had to wake up patients before because of that, when we're not complete, with our procedure, depending on what it is. We also use Recovera on a lot of our orthopedic patients now, and that alters our pre-anesthetic sedation, and also we don't do a CRI anymore, an MLK CRI. We just do LRS. We're going to record what controlled drugs we used for Max when we gave him his pre-anesthetic sedation. we use morphine and glyco, but morphine is the only controlled drug. So we are going to go to the morphine page, and we have today's date. Our starting balance was 1,160 mils. We'll have to double check the lot number on the bottle, but this is the amount, like different bottle numbers that we have for all of this. We only use 0.15, so we'll put that under used instead of added. So 0.15 mils that we use, so that leaves us with 1,159.85 mils. And then I just put my initials that I took it, and that way when they do the physical count, they can go back and see, you know, if they find any discrepancies. So we need to make sure that everybody's logging when they're using what drug. Quickly go through the anesthetic machine. It's hooked up to the non-rebreather right now, and most importantly, we have our oxygen hooked up, and we have a scavenger system that is also hooked up too. So we have our non-rebreather hooked up to our scavenger. This is the bag of the non-rebreather. And if we needed to bag a patient, we could disconnect that from the scavenger unit and close that off, and then bag using this. But always make sure to open that back up. We have, let's hook it up as if we were going to do a leak check. Actually, we are going to do a leak check. We have a 1 liter bag, small tubes. We need to hook up our, I think you actually have to have your scavenger unit hooked up in order to do a leak check. This is more of just the oxygen, but we're going to pretend like we're getting ready to do a procedure. So we have our oxygen hooked up, and we have our pressure gauge right here, and we're looking for centimeters of water. That's on the bottom. So close off your pop-off valve, and that's to help hold the pressure. And then we have our flush. So we want to fill that bag. The smaller the bag, the better. And the problem is I didn't hook this up correctly, so there's where the leak check comes in really important. You know, it's very, very important, because if I had a patient that was hooked up to this machine, it's not ready to be used. So you want to do a leak check prior to every procedure. So now I'm going to try it again, and it's filling up, and we're holding. I'm holding that spot, and it's not going anywhere. So go ahead and pause it. Okay, so we have our flow meter here that helps determine how many liters of oxygen we are administering to a patient at any given time. When they're under anesthesia, you want to do 1. If it's strictly oxygen, you want it higher. We usually do about 5. So we only use isoflurane in our hospital. So we have our vaporizer back here, and this is how we determine what amount we're going to be given. So we have to press this button down and turn it. So this is what determines how much anesthesia is going to be given to the patient. But if your oxygen isn't turned on, you're not going to be getting any ISO flow to your patient. And this is the level of isoflurane that's in your vaporizer. You want to make sure to check that. Keep the pregnant chicks away from it. It's bad for them. We do have a portable oxygen tank, which we only use in emergencies, but we check to make sure that it's full. Yeah, I'll do it. So one thing I wanted to go over real quickly was using masks with induction. Sometimes actually we will pre-oxygenate a patient prior to inducing and anesthetizing brachycephalic dogs, dogs that are in heart failure. Often every time we do a bronchoscopy. So you want to find the appropriately sized mask for your patient. You want a nice tight seal so we're not actually losing oxygen, but it's even more important when you are using a mask for induction, because we want as much ISO as possible to be going into the patient and not escaping, because that is dangerous for us to be inhaling that. So we'll set that aside. We are going to go through the items that are necessary to induce a patient. So, assuming the patient already has a catheter in, you would induce propofol, and then, I'm sorry, I said induce, but I meant intubate. So we are going to definitely need a tube, and I'll go over how to measure size, appropriate size for the patient. We need a tie once the tube is placed, but for anything, we need to use the laryngoscope to look down. Sometimes you need to fiddle with the epiglottis, and it's nice to have that light too. And then we have a little bit of lubrication that we put on the endotracheal tube. Our anesthesia machine is all set up. We're going to go through some more of the details on that, but make sure that's all ready to go before you anesthetize your patient, because you don't want to be messing with this when you are not ready. The patient needs to be hooked up right away. And then once you're all done prepping and you need to move into surgery, then you can we use this table a lot of times. It's nice and sturdy. It's kind of clunky, but it seems to work really well. We also have a stretcher that we can use if necessary, but we don't tend to use that very often. And with smaller animals, we can, if we're really careful or have somebody assist us, just carefully pick up and move into the surgery room. Careful to maintain asepsis. Okay. So we're measuring for our endotracheal tubes. This is a 6 millimeter tube. The best way to measure on especially a smaller patient is the very end of this. You would hold it up to their nostril. It should be the same size as their nostril. I don't think this would be a good size for me, but and then for length, oftentimes we just accommodate the appropriate length with our tie. We don't just shove it all the way in. We feel the thoracic inlet to make sure we're feeling the very edge of the endotracheal tube, and we don't want to go any further than that. It doesn't even matter. I mean, it's not ideal that it sticks out pretty far, but as long as we tie it in place, then and make sure it's not getting bent and twisted all over the place. But I'm trying to think if there's anything else that I need to cover, but a lot of times it's trial and error because the brachycephalic dogs are going to need a smaller tube than you would assume, as they have a smaller airway. And yeah, sometimes it's just genetics. You don't know what you're going to get until you get in there, and then you just need to be prepared to grab a different size if it's too big or if it's too small. We're putting the catheter in Kinsey, placing an IV catheter. So we're going to shave the area on her vein, cephalic vein,
It's the most AEC gave overnight.
and then we're going to scrub.
Big dose.
We'll do a minimum of 3, starting with the thorax. Start in the middle and work your way around in a circular motion. Don't ever go back towards the middle.
Because it's the same stuff that we have.
You get 35 more
Yeah, it's
around.
Pay attention to what you're looking like. If it's really dirty, there's actually a lot of hair on there, so it kind of looks dirty. But
One time,
she's a pretty clean dog.
I was on the third.
Oh,
Been there twice.
how's that medic going right now?
No,
Already gone. Darn.
An Alipro in there.
Okay, that's our last one.
Throw some like those.
She's got a nice vein.
No.
So,
I believe.
Well, I'm gonna put this last visit.
hopefully it'll be an easy poke for us. Doesn't always work out like that though.
Yeah, it'd be nice to know what they did last night.
Let's see a date on this one.
Again, just like when you're drawing blood, you want your bevel up, and then once you start getting blood back, then you can advance it a little bit, and then you only want to advance your catheter and make sure. Go ahead.
We have a page of record.
Okay. Go ahead. So first thing we're gonna do is tape this catheter in, and then we're gonna hook up the fluids and make sure that it's flowing properly. Make sure your tape isn't too tight, but secure enough so where it's not going to go anywhere. Grab the fluids. Sometimes this can be a little bit messy if they have really high blood pressure or you don't hold off well enough. So got that secured. And I'm going to also tape this part before we check it, so I don't want to lose my catheter. We've started using T-ports. It's just direct access to the vein closer instead of farther down. So, and now we will check to see that we're flowing, that we have a nice solid drip there, and then we're not, the vein, nothing's blowing under here, it's not going sub-Q, so it looks really good. So we'll close this off. We don't want to bolus a whole bunch of fluids. And then, need bed wrap. And you want to make sure to put triple antibiotic ointment, oh, we already have it, on a 3x3 and put that on the catheter site. And then we'll put some vet wrap on there. Let's use the rest of this, I guess. And then we will just make sure to secure this, tape it. We want to have tape actually securing that T-port, but also making sure that it's on the fur a little bit too so it doesn't slip down or move around. So, okay. I put a catheter. This is Sophie. She's going to be spayed today. We actually did try to put in a catheter in the cephalic and it didn't work, so actually we're going to try back here, trim up some of this fur around here so the tape sticks. Okay, and then we'll scrub. Starting with our Chlorohex scrub, start in the middle and then work your way out. We're going to do 3 of the Chlorohex and then the alcohol. Making sure to never go back towards the middle. 3 of each. One more.
Stacy, Jag's owner's here. Do you want to go over stuff with him, or did you kind of go over everything?
He's not going to come back.
Okay.
He lives in Berlin.
Yeah, I know. Unless does Dr. Les want to talk to him at all before he leaves?
Oh, did you?
Or
oh, you
someone
already
switch
got
with
that
me?
out.
'Cause I can. How did you get here so fast from Burlington?
Did they stay in
Oh,
town?
I think they did.
So bevel up. We're starting to get some blood back, so we're going to advance it just a little bit. Because that was kind of the issue with the cephalic. Okay, Stace. I think we're good. Alright. Surprisingly enough, this went smoother than the cephalic, but sometimes that's just the way things go. Shut up. It does. My professor's going to be watching this. Okay, so then we'll tape it to secure the catheter.
Yay.
And then we're using an injection port on this instead of fluids because it's a young patient, but we have direct access to a vein if we need it. And then we will flush to make sure it's patent.
Frankie never fit into him either.
They're so hard.
I know they are. I really wanted to force his little feet in them, but they never worked.
I did force
Yeah.
to feed it, but they're like,
You're not gonna.
you really
So
like
we're not
somebody,
blowing
but-
it all.
Yeah.
It's really good. So I'm going to finish taping.
Ear.
Okay, and then we will Oh, we need some triple antibiotic on the catheter site. Oops, sorry. It's not really an ideal spot
Hey Morgan, did you
if she wakes up rough from anesthesia, but something's better than nothing. Okay. Okay, so this is Sadie. She's going to have a dental procedure done. So we are going to intubate her, but first we are going to induce using propofol. So we have 20 cc's of propofol here. We may not need to give all of that, but we're going to start with 15 and see how she's doing. So we have our IV catheter placed already, and it's patent. So we'll go ahead and induce. Okay, so we are at 15. We'll see if she is ready to...
I don't think she's ready.
No? Okay, we're going to go ahead and give it the rest of that. Oh, no, definitely not ready.
She just likes to pretend she's usual.
And we'll see if we need to give any more than that, but let's start with that. Alrighty. Left hand with this, and right hand with this. Okay. Sorry. Oh
Pull
boy.
down the larynx. That's a lot.
I don't.
So you have the soft palate in the way right there, so don't kind of push up on that. And press it. Push
Oh,
down. And
uh-huh.
there's your hole.
That's my problem, I think is...
Epiglottis is in your way in the soft.
Okay, so then we're going to set this aside and then make sure we're going to feel the thoracic inlet. And sometimes they'll kind of cough a little bit and you can feel air coming out of here. And I can feel it in the thoracic inlet, and I felt a breath of air. So then we're going to tie behind here, behind our cuff.
A little bit farther back.
And then the rule is to tie behind the ears when it's a dental procedure so it stays out of the way. And then we will get her hooked up to the machine right away. She's turning purple. She is. Okay. Leak check this machine on this patient just to make sure we're not losing any ISO, and it's a nice tight fit for the tube and the cuff. So what we're going to do is close this off and listen for any hissing coming through there, or if you can smell any ISO, and we can't, so it's a nice fit. Okay. Okay, so one thing I forgot to mention when leak checking, we need to make sure we're holding pressure. So we're going to not only listen, but we want to check to make sure that our pressure gauge is holding when we close it off, and we're holding just fine. So this is perfect. Go ahead and give, this is Max. We're going to give him his pre-anesthetic sedation. We already did our TPR and listened to his heart and lungs and no abnormalities. So we're just going to give this sub-Q. So we pull up the skin, make a little tent. It's kind of hard to see when they have long fur. Draw back, make sure you're not getting any blood, and then check. There we go. We're gonna do spay on Sophie today, so we're gonna clip her. We already expressed her bladder and lubricated her eyes after we intubated her. So now we're gonna shave her and then scrub. So we're gonna start at the xiphoid process and clip all of the hair off. You want to get it as close to the skin as possible, but just to start, do a quick outline of where you're going to be shaving, and then go back over and get the finer stuff. And we're using a V-tray to keep her steady. We got nice fur that shaves really well. Some breeds have very difficult fur to shave. can pause it for now, Jamie. Away from me. Okay. So now we're using a vacuum, a shop vac, to get all the excess hair off of her, and then we're gonna scrub. And one thing I forgot to mention when you're clipping, if it's gonna take you a long time, just you always have to be paying attention to your blade. If it's getting too hot, make sure it doesn't burn the patient. We have spray to help cool it off. But hers was a quick
Yeah, and that was up front.
scrub, so we didn't need to do that.
I don't think there'll be anything else that we can't answer.
So just like you would for a catheter,
I
you
got
want
it.
to start in the center and then
I mentioned
work
to
your
him
way
if the bunch is down and take it off.
okay. Around.
So pressure sore, and I kind of warned him there'll probably be a big bruise there.
Yeah.
Where that was bleeding a little bit. Should be good to go.
Never go back to the middle.
But I just wanted somebody else to know in case I wasn't getting this
Dana, if you get a chance, would you mind making some more scrub and alcohol? Because I'm going to have enough for this one, but there probably won't be enough for the next one. Scrub, yeah, but not alcohol.
Are you videoing?
Yeah, that's okay.
Just about finished the bowl.
Hey, this is everyday life. This is for real. Oh gosh. I apologize for that. My 40-year-old co-worker is very mature. So then we both.
Yeah.
Scrub's getting a little bit low.
Might as well
So
just make
keep
a book.
checking your swabs to make sure they're getting cleaner. She still needs a little bit more. Okay, Jamie, you can pause it. We're going to simulate CPR on Fiona. Much easier to simulate doing CPR on a patient that already looks like she might be dead. Well, I think she's waking up a little bit. We're going to simulate CPR on Fiona. She's under anesthesia for a dental procedure, so it makes it a little bit easier for us to simulate CPR. As long as we know that our airway is patent, we want to focus on compressions. And with a small dog, you're going to put, using your strong hand, your dominant hand. I do the 3 fingers underneath her body and then use your thumb to do the compressions from the top. And with smaller patients, even larger patients, obviously you're going to need more to hold them in place, but when you're doing compressions, you're pushing down pretty hard and they get jostled, so you want them to be held as steady as possible. It's a little bit easier with the smaller patients to do compressions than it is the larger ones where you're using your whole body. But we already have our tube placed on our patient who's crashing. Luckily she's not crashing right now, but she's doing really well. But we would focus on doing the compressions 1 to 2 per second. I moved Sophie into the surgery room, so we're going to shut her. We turned her up for a little bit so that she would be sleepy enough for the transport. So I'm going to shut off ISO and oxygen, and then turn this off first, and then disconnect our anesthetic monitors, and then carefully transport. We're going to do one last scrub in there in case we accidentally bump her. everything set up in here already. We'll go through some of that here in a little bit. But. Oh, yeah. So we'll do that final scrub in here. We want to get her turned up right away so she doesn't wake up. Turn her up to 5 just to make sure she's not going to wake up, and then we're going to tie her legs. First you want to get your machine hooked up, everything hooked up and going so that you can keep an eye on vitals. And then once those are going, then you can tie her down. So we have our SpO2 monitor, our respiratory, this is our end-tidal CO2, captive breath. And then we're going to hook up our ECG leads. Right arm. And then we'll use alcohol to monitor. Okay. And then we could probably turn her down too because she's not picking up. Okay. I'll do that. Let's do the save on that. Sure. Okay, Jimmy. Okay. Ready? So we're going to do our final scrub in here. She's all hooked up to our anesthetic machine and tied down. I think I'll just do a quick 3 in here. You want to have your cap and mask on for this as well. Okay. We'll go over, this is our Cardell monitor, and this is what we use for monitoring anesthesia in addition to manually checking certain vitals. So we'll start with our ECG leads. We use the 3 leads. We have the red is for the left leg, white is for right arm, black is for left arm. So you're going to hook those up to the skin on the arm, or front leg rather. Pinch it kind of on the elbow skin area. And then on the hind legs, I would say you would consider it kind of like the knee area that you would clip it onto. And then you want to make sure you spray it with alcohol. So hook those back up. And then we have our means of checking our respiratory rate and end-tidal CO2. So we would hook that into the very end of our tubes. Hook that up in here. Every time the patient breathes, it's going to measure our end-tidal CO2, and it's going to count a breath. And then it'll calculate it for every, how many breaths per minute. And then, I'm just going to set this over here for now. Then this is our SpO2. It has 2 functions. It's going to, actually it's our pulse ox, I should say. It has 2 functions. So we're checking our oxygen in the blood. So it'll be a percentage, and we want it to be in between 95 and 100. Anything lower than 95, you want to start becoming concerned about mild hypoxia, and anything under 90, definitely very, very concerning. But it also measures our heart rate as well. And you want to have it on a mucous membrane. Like if you can get it on the tongue when they're anesthetized, that's perfect. Make sure the tongue is wet. Sometimes if it's dry, it'll not pick up very well. But you can do an ear, you can do a prepuce, vulva. There's a lot of different places, or sometimes the lip or the toe, depending on the color of the patient. And then blood pressure cuff, you always want to measure, and it always depends on what procedure is being done, what leg is going to be up. You want it on a leg that is up if the patient is in lateral recumbency. You can use it on a tail in a cat, but you always have to measure, and I don't know where our measuring device. So now that we've measured how to determine what size cuff we want, we would put it on the patient's leg or tail, and make sure you're paying attention. There's one side that says this side to patient, so that'll be the side that you will put to the patient, and then Velcro it around. Make sure it's not too tight, and you don't want to pull it as tight as you possibly can. Just a nice fit, and then that will tell us our blood pressure. We have our systolic and diastolic and our mean. So usually pay more attention to the systolic than the diastolic. And then we have our esophageal thermometer, and obviously this goes on the esophagus and determines internal body temperature, which is really nice. Also, when we're doing dentals, we can put this in the rectum too, with lubrication. And I think that's it. Okay, so we are, she's just finishing up. She's suturing using 2-aught PDS on Sophie for the spay. It's driving me nuts. So I'm just going to check some vitals on her, and we have our temperature, 98.8, respiratory rate is 12, end-tidal CO2 is 48, and this is our blood pressure right here, and then we have our heart rate, and then SpO2. We just turned her down a little bit because she was getting a little bit deep, so we'll go through our form and mark where we're at, and we've got symbols over here directing us as to what symbol to use for what value. When you are monitoring anesthesia, in addition to your electronic monitor, you want to pay attention to the patient itself, checking the blink reflex and jaw tone. If it's really loose, that's going to indicate a deeper anesthesia plane. If they're starting to blink, you might want to turn them up a little bit. Check mucous membrane color. Just don't rely on your machines entirely because they're not always accurate. I'm going to open up the surgical pack for Dr. Wedeking. Make sure your tape is it's completely sealed, it's not broken anywhere. If it's broken, assume that it's not sterile, get a new pack, and then we have our sterilization tape here, letting us know that it's sterile. So we're going to open this carefully. Be sure not to touch the inside of the wrap at all. Carefully open this up. And if you need to adjust anything, do it from the underside. And if you touch anything on the inside, you're going to have to get a new pack. So you want your drape to cover your mail stand. Okay. Okay, and then I'm just going to put the blade on here for Dr. Wedeking. We don't have a lot of extra instruments to use for the spay. It's all in here, so if she needs anything extra, then she'll ask us and we'll bring it in for her during the surgery. And all the way up in my... Oh, you're filming. We'll do it. We'll do it all. It'll be so clean. So I'm scrubbing in for the spay. You want to make sure your fingernails are nice and short. You don't have any jewelry on. Don't have your fingernails painted. You're going in every nook and cranny. You want to scrub up your forearms. You want to do this for 2 minutes. Okay, then you can pause it. So, when you rinse your hands, you want to make sure they're up against the water's flowing down. And then when you dry, make sure your towel is not touching anything it shouldn't. Use the one side to dry the one hand, the other side to do the other. And then carefully get your gown on, only touching the inside. And make sure when you pull the gown out, it doesn't touch anything that's not sterile. Don't put your hands out. Keep your hands inside the gown. The part I'm really bad at is gowning or gloving. And which side do you usually do first? The left?
I don't think it matters. I just use my left.
Just terrible at this. Oh, my gown is falling off. So in about 16 minutes, I should have everything all posit. Is that an S3? Yay! You filming? Okay, one down. We're only 6 minutes in.
It will help if you have your fingers exposed so that you can at least hold the glove, slide your fingers in without the...
I didn't think that I could do that.
Oh yeah, your fingers can be exposed as long as they're not touching any of the outside of the glove. You know, it's folded, the top is folded over, so... Okay, so stop,
I can...
Stop. Put the glove back down. So you want to hang on to the edge of the glove where it's folded, because this is where you don't want that hand to touch this part. So hold on down here with this hand, then slide your fingers in, yep, because this is all going to be inside.
But I feel like, yeah,
Yep,
yeah.
yep. And then, just don't let it play up with the cabinets. Okay, so then you can move that hand down and grab on down here if you have to.
Okay, Jamie.
Watch where your glove is though.
You filming? Oh.
Okay, yep.
Yeah, and at this point, as long as I don't touch, I can forget it. I'm gonna leave it. Okay?
Yep.
I can touch all
So
this.
yep, everything out there should be sterile. Just don't go on the inside. Okay, there you go.
Yeah!
Okay, your gown or your drape is ready. So I have my whole here. It needs to be like this. Okay.
So then I
You have
just,
to open it and.
aha. And then, but am I,
Nope. Do you see my hole right here?
yeah,
That's where I want to open the umbilicus.
okay.
There we go.
So, open, and, wait, can we adjust at this point?
Yeah, we can adjust. You just want to make sure that anything, that this was never in the non-sterile field. So ideally we would have done that a little bit differently. When we get done, I'll show you one more time. Then we can practice when we're all done. Just do it one more time. It wasn't bad, but it was way up here and we wanted it to be down
Down
here.
here,
So
okay. But,
I don't think you touched anything non-sterile.
okay.
Okay. You can do that top one.
So where do I put it?
Right at the top of the grate. Yeah, but no.
Do I?
Nope, nope. You want to get both. There you go. Both sides.
And then I pinch the skin?
Yeah. And make mine. Open for the bottom.
Both sides.
Scalpel.
So I'm going to go ahead and hand Dr. Whitaking the scalpel carefully with the blade not pointed towards her, but also not cutting myself.
Just for a little bit. Do you want to identify what we have?
No.
So we have the ovary and the uterus.
Okay.
And I'm going to be placing a clamp on the vessels while I remove the ovarian pedicle vessel clamp and place a hemoclip on it. This is just maintaining the tissue. Okay, so now I'm going to go ahead and make our cut and we'll release that ovarian pedicle and then Jessica can take the work on breaking down the ligaments. So you always want to make sure the whole ovary comes out. So what I have to do now is break down the ligament here. So I have to find the uterus and then I have to write this down and I'll have to hold the rest of it. Alright, go ahead and pull that for me. Okay, thank you.
So we got our instruments soaking and we're going to scrub them, but in the surgery suite itself, we're going to replace this keypad every time we have a surgery. It doesn't even matter if there's urine on it. And we'll put a new one on here, change out the garbage can, mop if you need to, if there's blood or urine or anything on the floor. Make sure you clean off. This is our temp probe. It goes down the esophagus, so we're going to clean that off really well. And all of these, the equipment over here, the probes over here, make sure those are all cleaned down because we don't want to transfer anything to the next patient. We'll spray our table with lemon cloth. I'm sorry, I'm real close. But here. Almost done. So spray down the table, clean underneath, make sure there's no blood or urine on the warm water pad. And then replace your keypad. Make sure your tubes are set up for your next patient. We're going to clean up the surgery room after our spay, so we'll just grab the Mayo stand, and we already have our sink filled with water. We use Spectra soap. You want to get them in the sink as soon as possible, but definitely within 10 minutes. Get them soaking. Be careful. First thing you want to do is look for your blade. Remove that very carefully. Put that in the sharps container. So we'll get this all cleaning, and I'll actually demonstrate quickly. I'm not going to do the whole surgery pack showing you how to do it, but
But
That's fine.
okay, there you go.
I'm super close up on my hair. Okay, ready?
It's going.
So we're gonna scrub the surgery instruments really, really well. Make sure to get in those cracks. That Spectra soap does a good job of helping loosen that blood up for you, but make sure you scrub it really, really well. And then for anything extra that we've missed, scrub it in the cracks too and the little hinges. And then you want to have it open when you put it into your ultrasonic cleaner, and you'll set that for 20 minutes. And then once that is complete, we'll do our 20 minutes in our ultrasonic. Take it out, and then we rinse, shake off, dry, and then spray with Spectra Lube. Obviously, I'm going to have to go through that entire process with all of these instruments, but then I'll show you how to pack them up. We are going to wrap our pack that we just used for our spay. We already scrubbed it, went it through the ultrasonic, dried it, and lubed it with Spectra Lube. So we're using, we have an outer wrap, and then our inner wrap is a drape. We need 3x3s. Probably a few more than just that. Sterilization indicator that goes on the inside. position. Those are used to drape the patient. And then we have our list of instruments for, this is our black pack, or pack number 1. So, actually, we dried it, didn't lube it yet. So we'll take this and make sure these instruments are all dry, lube them. Okay, and we're all ready to go. So there's a list. I actually like to put it in a specific order. That way the surgeon knows where everything's going to be every time. It's not chaotic when they open up the pack. So we have our scalpel handle and thumb forceps. I lay those right over the indicator strip, or next to it, rather, so you can see it when you open it up. And then, using our left hand,
I'll start filling it up
we'll
again.
just start going through the list. We have our needle holders,
Then I'll fill it up again.
and then
Or fill it to.
straight angiotribe. I'll put that thing on. Straight Carmel. Just one, and then we have 3 curved Carmels. Curved Cryos, 2 of those. There we go. Straight mosquitoes. 2 of those. 2 curved mosquitoes. Don't lock your instruments when you put them in. Just make sure they're all loose. Straight Mayo scissors. Straight Metzen bombs. Curved Metzen bombs. So now I'm running out of room on my hands, so I'm actually going to go over here and lay these out. Put our OH hook down at the bottom. And carefully lay these out. Nice and neat. And then, at this point, we will get our hemoclips and hemoclip holders. We have a little tray for the black pack. Make sure it's dry. We don't want any rust on that. There's a couple drops on that, so I'll put that at the end. Hemoclip holders there. And then we have towel clamps. Total of 8. We only used 4 on this last surgery. The other ones are all ready to go already. Make sure to lay them as flat as possible. Okay. And then we'll lay our drapes over top of that. And then we will fold it, wrap it, like we would a gown at this point. So top corner over, right side over, make sure it's nice and smooth. Left side over. Tuck this in. Top. Do the same thing with the outer wrap. And then we will put our tape on the outside, identifying what pack it is, who packed it, what the date is that we sterilized it. We have a little tab on the top there too. And then we will, I don't know if I mentioned, we also need autoclave tape on here to, before we run it in the autoclave, to make sure that it's sterile. Okay. We're gonna demonstrate how to fold and wrap a surgical gown. So first thing we do, I like to use, these tables out here work really well, and we'll have the front facing up, and then the sleeves are hanging down, so we'll just start with the sleeves, tuck them both in, one at a time, and then we're going to bring up the sides and meet in the middle, both sides. Make sure you clip the strings in as well. And then we're gonna do the same thing again, meet in the middle. Alright, and then at this point, this is where we would fold it over on top of itself, smooth it out, and then do an accordion style when you go to fold it up. And wrap that underneath there, and then we'll need a surgical towel, which we also do accordion style. I like to have it loose so that it's not difficult for the technician or the doctor to unfold. And then I just have a little tab here. Then we have our inner wrap, which is just a drape, and then the outer wrap as well. So we'll start with the drape.
And then it's all slippery, so you're like,
Make a little diamond shape, and then we take our top corner, pull it down nice and tight, smooth everything out. Right hand side over, smooth everything out. Left hand. And then this comes into the middle, and we pull this up and fold it in nice and tight, but you want a little tab sticking out so it's easy enough for them to pull it out. And then we'll do our outer drape in the same fashion. Sorry. Okay, and then we use tape. Make sure you are using, to save some money, we use masking tape for writing, for most of it. We write what it is, gown and towel. Who prepared it, and then we have this little circle that when it's sterilized, somebody will mark that they checked that it was sterile, and then we have sterilization tape for the autoclave. We're gonna load up the autoclave and start that. We're gonna do a pack setting. We've got a few of these packs already wrapped up. And you don't want to overload it. And if you're doing pouches, you want to make sure that they're parallel and they're not just piled on top of each other. It can overheat the autoclave or make it so that they are not sterilized. So make sure you have enough water. I know it's hard for you to see because it's just been through a lot of use, but there is enough water in there for us to run this cycle. So then we are going to close this, make sure it's locked, and then we select packs, which is 250 degrees Fahrenheit for 30 minutes. And then we're going to go ahead and hit start and get that going. And if we were going to do pouches and packs are the two most common things that we do. Pouches, I think we would do 270 degrees at 27.1 psi for 5 minutes and then 30 minutes dry. So it takes a long time. But we also every once in a while have to do we flash our instruments so it would be on the unwrapped. We can customize this, but we usually just typically select the appropriate button and then hit start. Make sure we clean it out once a week, and then we do the in-depth autoclave cleaning once a month. We're going to discuss the various types and sizes and shapes of suture needles and patterns and materials. So to start, and I'll show you some pictures that'll help with the process. We're going to start with needles. So I'm going to go ahead and show you. Let me turn this around. What we're looking at here is the different types of needles. We have 6 in total. We have taper point, taper cut, regular cutting, reverse cutting, spatula point, and blunt point. Typically, what we use is taper and reverse cutting. So, primarily for the needle types, the taper point is used for hollow organs, and taper cut is used for tougher fibrous material. Also, it can be used in certain cardiac procedures, and the benefit of using the taper is it's a sharp point that penetrates tissues without leaving small cuts. The cross section is rounded. For the reverse cutting, it has 3 cutting edges on the point, and it's much stronger. So the the spatula point, you can use for ocular procedures. And the sizes, there's many different sizes. Let me turn this back around. So our sizes range from 11/0 or 11 zeros to number 5. And 11/0 is the smallest, and that would be used for something like an ocular procedure. And then as you get higher, like in the sizes that just say number 1, number 2, number 3, those are typically used in large animal procedures. So we're going to talk about suture material. We have either natural or synthetic, and synthetic is used much more than natural. You can use, for the natural, you have catgut and silk and cotton. Synthetic is typically going to be monofilament. For the monofilament, it's a single solid strand, and the benefit is there's less tissue drag, but it needs more ties than the multifilament or the braided. And the braided is 2 or more strands that are tied together. And then we break down into the non-absorbable and the absorbable suture. Non-absorbable, you will see in a lot of cases, it's used in cruciate repairs. Even if it's left inside the body, it doesn't always have to be absorbable, and hopefully the patient doesn't have a suture reaction to it. Absorbable, the absorption can actually begin as soon as 7 days after the suture is placed. And a lot of times it's going to be subcutaneous. We use it with our neuters, and it seems to work really well. We don't have too many suture reactions. We see more suture reactions with our spays, typically. For our suture patterns, I have some pictures here, actually from the book, that demonstrate really well. Most commonly used is the simple continuous suture pattern, and it's most frequently used, you definitely use it in the skin, muscle layers, subcu space, and it makes for a nice and easy suture removal too. See this often with our orthopedic surgeon. He will use this for his orthopedic repairs. And then we have the Ford interlocking suture pattern. He also will use this. Actually, he uses this more frequently than the simple continuous. And you just, when you go to remove it, you're just going to snip and then just pull as you go along. Sometimes it's a long strand. You don't want to, you want to kind of just pull as you go, just one small piece at a time. And then simple interrupted suture pattern that we just used on our spay yesterday. And it seems to hold really well, but sometimes if you pull the knot too tight, you can have a tendency to have some bunching in between the suture. And also, like I had mentioned before, a suture reaction in this particular case. And another that we use more frequently, there's a horizontal mattress suture pattern. We don't typically use that very often. And then the cruciate suture pattern, which makes an X over the incision. But again, when we do our sutures, for our orthopedic surgeries specifically, we're going to stick with that Ford interlocking suture pattern. We're going to remove some sutures on Sophie, but when we took a closer look, you can see that it's still red and it's not quite healed. So if we remove those sutures, it's just going to come apart and we're going to have to resuture it anyway. But I'm going to demonstrate how we would do that. There's knots, and you just snip through the suture, the knot right here. It's actually 2 knots on this one, and then just pull. Just do it gently. Sometimes they're sensitive with the suture removal, but usually they just don't like to hold still. So we would just put, you can see on your suture scissors, this little notch. You want to slide that underneath the suture and then snip it. Make sure they're nice and sharp so you're not having to do it over and over. But it's just a little bit tender right now, and things you want to pay attention to with the incision is major redness, discharge, or swelling around it, or hot to the touch. But at this point, we're not quite ready to remove Sophie's sutures.